Okay.
To start us off.
My camera's over here, my screen's over here. This is why you see me at a different angle. But welcome, and we're so excited to have you participate in the January 20th Year 2 session of the Learning Opportunity that brings all our students together. Next slide, please. We certainly cannot do this without individuals. So the University of Manitoba campuses are located on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories and acknowledge the harms and the mistakes of the past and the present, and we dedicate ourselves to move forward in partnership with Indigenous communities in spirit of reconciliation and collaboration. Within the Rady Faculty of Health Sciences, if you don't know or aren't aware, just a bit of a brief overview that we've been delivering the interprofessional education sessions within this house of the Office of Interprofessional Collaboration since 2016. Many of you were involved previous with the IPE initiative at the University of Manitoba, which really resulted in this OIPC office. So it's 5 colleges: dentistry, medicine, nursing, pharmacy, rehabilitation, sciences, over the 10 programs on 4 campuses. And the listing of those professions is there. We are grounded in these 6 competencies, and Moni can go to the next slide. We have prepared an OIPC recording. If you want to, you can have that link. I also think you've also received the link, which will give you a greater overview. It's only about 10 minutes, but it gives these 6 competencies that we really focus in on within this collaborative curriculum that runs over a 2-year longitudinal time span, really focuses on these 6 competencies. So we really have a balance between how we help the students find themselves contextually in their practice settings or future practice settings in healthcare through the lens of these 6 competencies. And we do so using the theory around bringing student people together, but also through the educational theory about knowledge, cognition, psychomotor, or affective. So we refer to it as the know-be-do model, and we really aim for that sweet spot in the middle, which all our learning objectives are aimed towards. So these are our learning outcomes for the Year 2 curriculum. So interprofessional care as well as patient safety. So we contextualize the interprofessional collaborative care as a means of enhancing, promoting, assuring patient safety. So as I mentioned, our curriculum runs over a 2-year period. So the students on January 20th, in the red that's circled here, they will have been together for this length of time, engaged in in-person synchronous via Zoom sessions at the top of each term, and then engaged in discussion with each other, all of which are simulating a team. And the discussions either are via asynchronous, an online discussion, or this past year we introduced students have the opportunity to, through their own scheduling as a team, to locate a time that works best. Team discussions that occur via Zoom or however they together, and then asynchronous to achieve healthcare systems issues, professional and collaborative perspectives. The learners will be able to determine professional and interprofessional roles in relation to team function, communication, share decision-making process and outcomes, ensuring engagement in patient, client, family, community, and create a safe environment, enabling the team to take constructive steps to resolve conflict. So we really do, at this point in time, move into that conflict place. We sort of save that for the next slide, Moni.
I'm just curious, your sound is cutting in and out for me, and I'm not sure if it's doing the same for other people or not.
Oh, that's so unfortunate. I'm finished. I think, Moni, you can take over then.
Sure. So the agenda, and I have a dog that's barking in the background. Hopefully it's not too disruptive. So the agenda for January 20th for what you signed up for is a simulation activity. So we have hired standardized clients to help us with this process. But of course, we have, as Laura alluded to, this longitudinal curriculum, we have 78 teams of students who are participating this afternoon on January 20th. And so we're actually going to do like a split lab, if you've ever taught that way before. And we're going to be running 2 simultaneous Zoom sessions. But the agenda is here on this slide. Is going to start with an welcome and introduction. There is a simulation activity, and those who are not doing the simulation will be doing an activity around role clarification and role blurring, specifically in fall prevention, and then they're going to flip. Then there'll be an opportunity in each of the 2 Zoom sessions to do highlights and a wrap up. There will be an optional debrief following this session, one for learners and one for facilitators. That is an opportunity. It is completely optional, but it's an opportunity for us to get some feedback from you right away on how the session went. So in more detail, this is what the afternoon will look like. We've referred them to 2 waves, but you could consider them 2 separate Zoom meetings. There will be the 39 teams in the first one and 38 teams in the second, or whatever the math is. Each wave or each Zoom meeting, they will get through all the same activities, but in reverse order. Both of them will start off with a welcome, moving on to the simulation activity. Then the OIPC, our group, will be responsible for a little 5-minute summary. Then this on the wave 1, and then there's a break. And then we flip it. And then the simulation activity will move to the second wave. And so where we are asking for your help is in the sections that are highlighted in red. And we're going to go through this in more detail, which is why we're here. But you can also see on this overview that when the students are not doing simulation, they'll be working or discussing through content around role clarification. And then there'll be a wrap up. You yourselves, you will hear the welcome in the wave 1 before the simulation happens. You'll be moving over to the break during the break. And in wave 2, you will hear our final wrap up as well. So you'll hear everything except the section on role clarification. So when part of our welcome is going to start off by sharing a story. We have arranged for patient representatives from Shared Health, which was previously part of the Manitoba Patient Safety Institute for Safety, MIPS. It's now been subsumed under Shared Health. But we have 2 patient representatives who are family representatives, probably better described, who'll be describing in their own words, their own lived experiences around why teamwork was so important to patient safety and their own lived experiences. And so they'll start off each session for no more than 10 minutes to give that personal lived experience to why this is so important. Just a couple words on what the students are doing when they're not with you, when they're talking about role clarification. They are going to talk about everyone's responsibility across the health professions in fall prevention, including all 11 of our participating programs. Social work is joining us as well in year 2, as well as the programs or units, professional programs within Rady faculty, and they're going to be discussing the advantages and disadvantages to role blurring and role overlap. We have made an in-house document around what is everybody's responsibilities in fall prevention. All of the content has been shared with the right profession. So as a physiotherapist, I didn't write it for OT. I had my OT colleagues write their section, for example. We will share that with you so you know what the students have looked at, because for the second iteration that you're going to be involved in, the students will have gone through this already. And should the students somehow refer back to it, then you'll at least know what they're talking about. So we'll share that document with you. Next week, we're going to send you a whole package. But then again, the reason that we're asking for your involvement is the simulation activity. I didn't ask how many of you have been involved in simulation before, but I assume, like our learners, some of you will have done simulation previously and some of you not. Not all the health professional programs use simulation, but many of us do. So for the students, many of them will have done it. So we're going to start off this section talking about conflict, because the scenario, which I'm going to share with you right away, has to do with conflict, not between team members, but between the team and an angry family member. And so I'm just going to escape here, and I'm going to show you this video. Laura, can you confirm with me that you can hear it and see it? Yeah. Just increase my volume. There's no sounds yet.
The Kilman model of conflict management organizes 5 conflict management styles based on 2 dimensions: assertiveness and cooperativeness. People react differently to conflict, or better, conflicting interests. Every style has different degrees of assertiveness and cooperativeness. In other words, how much focus is on your own concerns and how much on satisfying the other person's needs. In any conflict situation, you may respond in one of several ways: by competing, accommodating, avoiding, collaborating, or compromising. The first style I would like to describe is competing. This is the win-lose approach. You act in an assertive way to achieve your goals, without seeking to cooperate, and it may be at the expense of others. This approach may be appropriate for emergencies, when time is of the essence or where you need quick, decisive action. Avoiding is when you simply avoid the issue. You're not helping others reach their goals and you're not pursuing your own. This works when the issue is trivial or when you have no chance of winning. It is also very effective when the atmosphere is emotionally charged and you need to create some space. The style collaborating can also be described as a win-win approach. This can be effective for complex scenarios where you need to find a novel solution. This can also mean reframing the challenge to create a bigger space and room for everybody's ideas. The downside is that it requires a high degree of trust, and reaching consensus can require a lot of time and effort to get everybody on board. Accommodating is when you cooperate to a high degree, and it may be at your own expense and actually work against your own goals. This approach is effective when the other party is the expert or has a better solution. It can also be effective for preserving future relations. And finally, compromising. This is the lose-lose scenario. Neither party really gets what they want. It requires a moderate level of assertiveness and cooperation. It may be appropriate for scenarios where you need a temporary solution, but the trap is to fall into compromising as an easy way out. Thank you for watching. See you next time.
Raviolis.
Oh my goodness, I
I'm
just went
terrified.
to
I don't
another
look like
video.
you.
Just
How do
carried
you
on.
eat like that and look like that?
Because I have an
I have a question. It's Chris here. In that clip, the compromise was a lose-lose. Did I hear that correctly?
Yes, you did. What we're hoping that where they'll go with this, let me just get back to the right slide again, is to get to oh my goodness, what's it doing now? There. Can you see my share? Oh, there, now you can. Yes, what we're hoping that the students are getting to is collaborating. That's what we're aiming for. The authors there did say compromising is lose-lose because neither of them gets their way, if you will. It's interesting. I'm not sure if probably been my life is made up of compromising, but yes, but the goal here is really about collaborating.
Okay, thanks for that clarification. That jumped out at me. And I wanted to know whether or not the students, it might jump out at them. So thanks.
And so I will also add that when we introduced this conflict model a few years ago, we did check with all of the programs what kind of curriculum they currently have on addressing conflict, and do they use a framework. And the units at the time who do address conflict and do use a framework, we're using this one. So it is, if they're familiar with the framework, it seems like the majority of the students will know this particular framework, if you will. But so that's not really the true emphasis as we're moving forward. This is where we're going now, and this is the case. So the STEM is typically what we call it in simulation. The learners are shared this scenario before they begin, and they're shared this in advance. This is the fictional case of Gene and his daughter, Marianne. Gene is an 86-year-old widower, recently admitted to the hospital with a suspected COPD exacerbation. At 0200 hours, he was found on the floor of the bathroom in his hospital room. An X-ray showed a fractured right ulna. His daughter has been informed of the incident, is angry over what she considers to be a lapse in care. She requests a virtual meeting with the team to discuss the care of her father. So the simulation is actually the discussion between the team and the daughter, Marianne. So there is some pre-briefing, if you will, involved in this. There's some background information that I'm going to share with you now around Gene, and this will be shared with the students in advance as well. In fact, it's already been uploaded for the students. So the case of Gene, there's two parts. The students receive a written word version, or that they have the alternative of watching it in a Powtoon. So shout out to our colleague Stephen Yerkew from the former Rady Office of Educational and Faculty Development, who created this for us a couple of years ago. Chris, you're the one on my screen. Can you, once I start, can you let me know with a thumbs up whether you hear it or not?
Gene is an 86-year-old widower who has been living on his own for 8 years.
You hear that, Chris?
He has hypertension,
Thank you.
HTN, heart failure, HF, NYHA class 2, and chronic obstructive pulmonary disease, COPD. Gene has periodontal disease, wears a partial upper denture, which is ill-fitting, and has halitosis, better known as bad breath. He smokes and experiences a chronic cough. He has been hospitalized twice in the past 2 years for exacerbation of heart failure. Gene has 2 children, Marianne and Ray. They visit him as often as possible, but both are busy with their own lives. Marianne, who lives in Thunder Bay, visits more often than Ray, who lives in Vancouver. Ray tends to think that Marianne worries about their dad needlessly. Marianne does not think her dad eats well, that his sleep is poor, and worries he will start a fire due to careless smoking. Ray and Marianne have decided that Marianne was to be the primary contact for their dad. 5 days ago, Marianne drove to Manitoba on a routine visit to see Dad and to take him to the Brook Dental Clinic because of an ill-fitting denture and halitosis. During the dental and dental hygiene visit, Gene stumbled getting in and out of the dental chair, catching himself on the arm of the chair to prevent a fall to the floor. A member of the oral health team witnessed the near fall. However, there was no documentation of it, though when Marianne met Gene at the door, she was told it happened. When Marianne took Gene home, to her dismay, the house was a mess. There was a kettle on the counter that had boiled dry, at least one cigarette burn mark in a living room chair, and a refrigerator filled with nothing but takeout containers, bread, and jam. In his bathroom, Marianne noted a crusty toothbrush, unflushed toilet, the sink full of facial hair, and pills scattered on the counter here and there in various rooms. Marianne decided to stay with Gene for a few days. Over those days, Gene appeared increasingly slow-moving, short of breath, irritable, and a little confused. Out of concern, Marianne took her father to the emergency department, and he was subsequently admitted to the hospital. Rapid testing for COVID was negative. Gene encouraged hospital staff to communicate with his 2 children regarding his care needs openly. When Marianne, Gene's daughter, brought him to the hospital, he was admitted. Day 1. Gene's symptoms included labored breathing, dyspnea on exertion, orthopnea, and leg edema. Each member of Gene's hospital healthcare team met with Gene and Marianne to assess Gene and develop their uniprofessional care plan for rounds tomorrow morning. A fall risk assessment is pending. Review of systems. On exam, respiratory rate was 28 per minute. Oxygen saturation was 94% on 5 liters per minute. Chest by basilar crackles to scapula. Blood pressure, lying, was 120/80, standing was 110/79, and heart rate was 95 beats per minute. Labs. Arterial blood gases indicative of COPD exacerbation. All other blood work within normal limits. Chest X-ray/imaging, signs of COPD, heart failure exacerbation ruled out. COVID swab negative. The list of medications prior to Jean's admission were noted. Impression: presentation consistent with COPD exacerbation. Day 2, progress note. 0 to 100 hours. Jean experienced fall when getting out of bed unassisted, exact time unknown. Found in bathroom in puddle of urine with 2 broken front teeth. Denied symptoms of confusion or dizziness. Patient complains of severe pain in his right dominant hand and arm. Right wrist is swollen, bruised, and painful with movement. Wrist X-ray ordered. Narcotic analgesic prescribed by attending. First dose given. Jean reports increased comfort with same. 0800 hours. Daughter, Marianne, called by charge nurse, informed about Jean's fall and diagnosis of fractured right distal ulna. Marianne seemed very upset by the news over the phone and demanded to know, in her words, what the heck happened, and wants to speak to the team. Issue to be discussed in morning rounds. Morning rounds. 0900 hours. Jean's situation reviewed. Fractured right distal ulna confirmed and immobilized. Team confirmed video conference with Marianne for 1100 hours. Team huddle. 10:50 hours. Pre-brief for meeting with Marianne. 10 minutes.
Okay, so the STEM, we will show students again the day of. It's also in Learn for the learners, but the Powtoon cases, we're not showing those during the event. Those are for the students to review in advance. They take a little bit too long. I know they're a little bit on the medical side. Invariably, we have learners who would like to have more medical background information, but the rest of the day, the activity is really not based on the medical considerations. This simulation is really about team communication with the daughter, Marianne. So if you personally don't have a medical background, don't be intimidated by that. We provide that information for the learners who really want it. So the simulation activity itself. So there'll be 35 minutes, 10 minutes of preparation before Marianne joins the breakout room. So the whole thing is happening in Zoom. We will have the learners join the breakout room that belongs to their group. So they're just in their small group. And they will have 10 minutes to prepare before Marianne, played by an actor, will join their breakout room. So this is all part of the pre-briefing, if you will. The encounter itself, when they speak to Marianne, should not be any longer than 10 minutes. Some of them will be finished in 5 minutes, but after 10 minutes, they need to move on. So 5 to 10 minutes, and that's typical. The standardized client will stay in the room when that encounter is done for 5 minutes of a team debrief. So the standardized client can give them some feedback, and the standardized client program, as part of the Rady faculty, they are trained in how to provide feedback. They use a model, and I shared the link with some of you in advance about the kinds of modeling they use. Then the standardized client will leave, and they're going to move on to that other Zoom meeting, getting ready for the next scenario, the next iteration. And then you will be alone in the group for 10 minutes to do a facilitator-led debrief. So there may be some groups that don't get a facilitator, but we know that best practice is having a facilitator present. A couple of notes here. Marianne will be played by an actor. Marianne should have Marianne written on their screen, on their name. If you are new to simulation activities because you've never done this, please remember to think of Marianne as you would a real patient's family member and maintain respectful communication throughout the encounter. So as part of the preparation, feel free to remind the learners to consider this an opportunity, a safe opportunity to really practice a difficult conversation. This slide will be shared with the students right before they go into the breakout rooms. They are expected to all have their cameras on. Now, we know that there's reasons why some people won't have their cameras on. A student might send you a message to say that they don't have the connectivity, but really we are hoping that they will all have their cameras on so that they're all engaged. Headphones preferred in shared physical spaces. There may be some students who are in a shared classroom. We have some students who are joining us late from nursing. And if they're actually sharing a physical space on campus so that their sound doesn't interfere with one another, they are being told to bring headphones. We cannot control where our students access Wi-Fi. They might be in Starbucks. They might be at home. We're not quite sure. So they might be they might have headphones on, and that's okay, especially if in their shared physical space. In this preparation, they need to decide on 2 to 3 students who can take the lead. So each group will have about 8 people. We can't anticipate that all 8 people will speak to the standardized client, to Marianne. So they need to decide on who's going to take the lead. But what we really don't want is the 2 or 3 students to all be from the same profession. So hopefully there's an interprofessional flavor to how they have the conversation. That's what we're looking for. The other students who are not having the conversation with Marianne, one should be a timekeeper, one might be taking notes, and the rest are observers. But observers have a very important role, and this is actually supported in the evidence in the literature, that observers feel very much engaged in this process, and they need to be part of the debrief process, but we'll come back to that. So there are more people than will actually be involved in the conversation. What we also want them to do in this preparation is anticipate what Marianne's concerns might be based on what they know. And they should prepare 2 to 3 pre-scripted lines in how they're going to try to address Marianne's concerns. They know Marianne is upset. They know Marianne wants to speak to them. So how will they begin the conversation with Marianne? Then the simulation itself, when Marianne joins the breakout room, do let the team role play without interrupting as a facilitator. This is not for marks. It's an opportunity for them to practice in a safe environment, allow them to take risks and to make mistakes if that's what happens. Now, people who've done simulation previously are familiar with students requesting a timeout. That's absolutely permitted. If a student says they need a timeout because they don't know how to respond to something that Marianne has said, that's okay. And the standardized clients are also used to students asking for timeouts. The team should be attempting to diffuse the situation, actively listening to Marianne's concerns. So we have given Marianne a script and some specific responses that we anticipate the actor to play. So we anticipate that the actor will be tearful and may sound angry in response to the learners, but no shouting. Like, get into the role, but not make people feel so uncomfortable that they get triggered by being yelled at. If the learners use terms like a fractured ulna or an analgesic, Marianne is supposed to ask, what's that? I don't know what that means. They're supposed to be using lay terminology. If the learners go on a tangent where they start discussing what will happen next, like, oh, well, they'll get physiotherapy after they get discharged, they'll need their dentures repaired, Marianne will ask, well, who's going to pay for that? He doesn't have any insurance. Interesting, shared health does not typically pay for things that are broken or lost while people are inpatients, while people are in the hospital. So there is no magic answer for this, FYI. If the learners acknowledge or empathize with Jean and their situation, Marianne should de-escalate.
Moni, before we move on to the next slide,
yes.
Dana has a question in the chat, and it's an excellent question, and probably one that we all face. What happens if there are no volunteers to take on the roles? What have people done in the past when that happens, even in one's own setting?
You're asking for people to share
I'm asking
responses?
what do people do?
Anyone wish to volunteer?
Dana.
I guess I would be inclined just to say, it's a valuable learning experience and this is a safe space to be able to practice the skills. But still that may not result in volunteers. So I'm wondering what to do in that case. Then are they being voluntold that they are doing it so that there are 2 to 3?
This is not a new activity. We have not encountered it, but you're absolutely right, we could. And then response would be more like well, they first of all need to submit their discussion using a template, a minute template, like a team. So somebody needs to take it on, and
I think you could, that's where you as the role of the facilitator can say, well, we only have a few minutes, we need to decide. Would you like me to appoint somebody? And then they'll hopefully say no.
Usually that usually does result, but again, what if nobody does? My goodness, that's a worst case scenario, and then I guess it's a voluntold.
Yeah, I've never had that happen either. Usually somebody steps forward, and there's a group of 8 people. So yeah, I mean, anything could happen, the unanticipated.
And, as a facilitator, then I guess I might take pause for that opportunity to say, so what happens when nobody in a team does take the role of responsibility? Because documentation and note-taking is part of team responsibility, right? Michelle?
I would add one more comment there, that you can always come up with the pre-scripted lines as a group and then come back to ask them, because maybe somebody will feel more comfortable once they have the pre-scripted lines already set out as a group. That might change the comfort level of volunteering. Michelle?
So are these groups brand new to the students? They haven't been working into these groups previously, or they have?
A year and a half worth. They've been together.
So this should be less likely since they've been together for a long time. Okay, thanks.
For a year and a half. There might be 1 or 2 new students to the group, because every January there's always some movement between within nursing specifically, because they have such a big program and they allow part-time studies. So there might be 1 or 2 new people to the group, but everybody else has been together since the fall of 2021. And so then moving along through this, so then debrief with Marianne, cameras should all be on. So Marianne being the standardized client, and the standardized client will provide general feedback. And we've given the standardized client the direction of what kind of feedback we'd like them to give. And then the team debrief with you. And these are the 4 questions we'd like you to go through. Just give yourself a minute to read through these. Now, you are going to get a written document that has this all spelled out for you. There are no specific answers. It'll depend on how things go. We suspect that in the conflict management strategies, we're going towards a collaborative response. But in good practice, in simulation, you use a debrief framework. And I'm going to give you the example of how we'd like you to work through this. But for those of you who are less familiar with simulation, do remember that debriefing is not the same as a lecture. We do not intend for you to lecture anything here. It's intended to promote critical thinking of the group. Do allow the observers, this is where those observers are really key, allow them to actively engage in the debrief. And if there's complete silence, you might want to share an experience from your own experiences in teams where there may have been a conflict that went south. We'd encourage you to think about this in advance. Do you have an experience that you could share to not fill dead space, but if you're finding it is very hard to get them engaged in the conversation, role modeling the vulnerability and the chances we take when we're trying to deal with conflict, and sharing your own experiences. We have heard from learners that they really appreciate that. So that's up to you if you do have an experience or how you might deal with that. You might not need to do it at all. Again, these groups have been together for 18 months, so hopefully they won't be shy in speaking to one another at this point. But I did mention a framework. And so again, this will be shared with you in a Word document that you can print off and have in front of your computer screen so you can follow this along, as opposed to, you might have two screens, that's up to you. But the PEARLS framework is one of many debriefing frameworks available. This one is perhaps more commonly used in interprofessional simulation. We'll send you also the complete article if you wish to follow up and take a look at it. But this framework starts off by setting the scene. So this is part of your 10-minute debrief. And you could say, and you can modify this for yourself a little bit, but here it is. I'll spend about 10 minutes debriefing the case with you. First, I'll be interested to hear how you're feeling now that the case is over. Second, I'd like someone to describe what the case was about to make sure we're all on the same page. Then we'll explore the aspects of the case that worked well for you and those you would manage differently and why. I'll be keen to hear what was going through your mind at various points in time. We'll end by summarizing some take-home points and how to apply them in your clinical practice. So 10 minutes will fly by, I recognize that. So there's 4 parts after setting the stage in this framework. First is the reaction. And so here's how you could say it. What are your general impressions on how that went with respect to managing conflict with Marianne as a team? So not individual, the focus is really on as a team. And some additional prompts from the framework might be, how are you feeling and how are the rest of you feeling? Then, spend a couple minutes on that. And then the description. Can someone team-based point of view so that we're all on the same page? From your perspective, what were the main issues you had to deal with? The original framework says, can someone summarize the case from a medical point of view? I changed that to team-based because we don't want them to focus in on the medical part. We really want them to focus in on the team part. And what were the main issues you had to deal with? You might hear how difficult it was for them to actually deal with an angry family member. You might hear questions from the students saying, well, is that real? Could that ever happen? Yes, the answer is yes, absolutely. But allow them to identify what the main issues were. Was this a preventable fall? Maybe, maybe not. Hard to say exactly. But that's sort of what we see as the main issues potentially, but I do allow for some free flow conversation in that. Is there a right answer and a wrong answer? I guess the main message we're trying to get across is respond as a team, be collaborative, and don't throw any one team member under the bus, really. Then the analysis part, you as a facilitator could signal the transition to the analysis of the case and frame the discussion. Okay, so now that we're clear about what happened, let's talk more about the case. I think there were aspects you managed effectively and others that seem more challenging. I'd like to explore each of these with you. You don't have to use this prompt verbatim. It's there if you need it, and feel free to modify in the moment. We're encouraging you to move towards learner self-assessment or the team self-assessment. So you can ask what worked well and what did not work well. Let them answer the question. Which of the conflict management strategies did your team use? You can try to bring it back to there. It's not critical, but it's nice if they can weave that into the conversation, depending how everything's going. You do have certainly some flexibility here, responding to your team and however they are wishing to communicate through this. And then really importantly, the third question here, what would you do next time to improve the quality of the encounter or the quality of a conversation with a family member? Michelle?
I just wanted to clarify. So I assume in this analysis phase, we're trying to keep them focused on the encounter with the family member and not anything that could have been done before to prevent the fall or anything like that. It's solely focused on the encounter.
Correct.
Not them analyzing anything else.
Absolutely. And so in the other activity that they're doing around everybody's role in fall prevention, they'll have that opportunity to talk in general terms about fall prevention. But here we really want them to focus in on the communication with the family member. Yes. Laura, did you want to add anything?
Yeah, and I can see if the students were drawn to that side of the issue, is that Marianne is upset and she's worried about her father. She thought she brought him into a care place. And, so I would make that link with them because I can see that this is going to create angst for Marianne, the whole medical aspect of things.
Right. Chris?
I was just going to add that although this session is around fall prevention, I think it's fairly safe to say that, you know, in their work going forward, circumstances like this will occur in many cases, so that they can generally generalize the principles to what they will be working in the context as well as teamwork. So it applies across the board. This is just a way of
Absolutely.
Mhm.
Really good point, Chris. This is just a context to be able to
Yeah.
have this discussion. Absolutely. Some of them will never work in a hospital, for example.
Mhm.
Right. So I think that's really important because it's universal, these
Mhm.
kinds of conflicts, right?
Sure, and the also universal thing is around fall prevention in any setting that a patient accesses healthcare.
Absolutely. A shared responsibility that we all have.
Mhm.
And so then hopefully you'll have a minute or two to do a brief summary before we pull everybody out of their breakout rooms that day. You can ask, are there any outstanding issues before we start to close? And you might not have time to do both the learner guided and the educator guided sort of approach, but we're giving you two here. If you have time to do the learner guided, you could say, I'd like to close the debriefing by having each of you state 1 to 2 takeaways that will help you in the future. One might be enough, especially if you're running out of time. Or if you only have 1 minute and you don't have enough time to go through all the learners, could you say, in summary, the key learning points from this case were that you need to address conflict as a team. That might be your only learning point, I guess. But it depends how the timing is going and how verbose your team is, and on your own style too. And so you do have some flexibility here in how you want to actually adapt this for your own needs. Michelle?
And we'll be getting countdown timers for us to keep track of the time, I assume, in the Zoom meetings.
Yeah, and so
10 minutes seems really short to do all of this.
Yes. So we'll give you a 5-minute warning for sure, maybe a 2-minute warning. And then you also have the timekeeper within your group. But because the standardized client is giving you the 5-minute, some general comments before you're just by yourselves, hopefully that will make this a little bit tighter for you as well, because you'll have already heard from the standardized client how they thought it went. The reason why, you know, we could probably, if we had facilitators for every small group, we could probably justify asking the standardized client or skipping the standardized client feedback, maybe. But there are some groups who are not going to have a facilitator because we don't have enough facilitators for all the groups. Right now, we are shy about 10 facilitators. So if you know anybody who you think would like me to be interested in doing this, please do put calls out there and send them our way. But with the standardized client feedback, then for the groups who don't have a facilitator, they at least have the standardized client feedback. So we're trying to do a lot here. So again, this is what it looks like. First, in the first Zoom room or Zoom meeting or wave 1, they'll have the 10 minutes of prep, the 10 minutes of the encounter, 5 minutes with the standardized patient or standardized actor. They're an actor, they're not a patient in this scenario. Marianne's not a patient. I need to fix that. And then 10 minutes with you. Then you have, then we have them again, we pull them out into the large group. We have one slide just to kind of summarize the experience in 5 minutes or less, and then there's a break. So in that break, for sure, we need you to move over to the other Zoom meeting. So you will receive 2 different Zoom links for the one and then for the next. You move over and then we'll get you ready to go into the next breakout room. We will pre-assign which breakout room number or which team number you're going to be joining so that you know exactly which group you're going to be doing. So historically, we tried pre-assigned breakout rooms, but with this number of people, Zoom was too slow to accommodate the pre-assigned breakout rooms. We have found it much more efficient to use the feature in Zoom where people choose their own breakout room. So we will have the breakout rooms numbered by team numbers, and we will tell you in advance which team you're to join. So you'll just look up for that team and you join them in the breakout room. I hope that's kind of clear. And then of course there's the wrap up. We will still be setting some ground rules up for the learners. They're familiar with these. We've used these previously. That they need to be open and fair-minded, think about integrity and trust and respect throughout, and humility in the process. This is not meant to be a debate between the learners. It's meant to be a forum for open discussion. That to put hierarchy and power issues aside, this is meant to be a team-based approach. There will be this opportunity at the end for reflections. Again, it depends on timing, but we hope that we'll have 5 to 10 minutes just for some summary comments. Sometimes these things with technology, we lose these opportunities. If we have the opportunity to do this, if any student wants to bring something up, they can, but we don't have enough time to have all the groups actually participate in this, but we might call on you as the facilitators if there's any highlights that you'd like to share, but it won't be mandatory. We have to be a little bit fluid as we go in these big activities. The students, we thought we'd share with you what the students need to do in advance. They need to review the case of Jean. They will have a document provided, I mentioned this already, around roles and responsibilities for fall prevention. We'll send it to you as part of your package. Not that you're working directly with this document, but then you'll see what the students have. They will also be shared the clinical practice guidelines from the WRHA around fall prevention in acute care facilities, so that you'll know what they have. They don't need to read the whole thing, but those pages 14 to 29 talk about everybody's responsibility in fall prevention. And the WRHA came up with a series of fact sheets on each of the competencies for interprofessional collaboration. They're one-pagers, so they're very quick. There is one specifically on interprofessional conflict resolution that we're asking them to look at in advance as well. And now I'm going to stop sharing. If you do have any questions, you can certainly email them to us, but we also have some time right now to take your questions. I think I will stop the recording